Welcome to the Techy Surgeon Podcast.
You know?
All right, let's do it.
Okay, we'll get started here. Okay. Welcome everyone to the inaugural episode of the Techy Surgeon Podcast. I'm Dr. Christian Payan, board certified orthopedic trauma surgeon, CEO and co-founder of Revel AI Health, an AI care navigation platform, and your host at the Techy Surgeon. I am extremely excited to welcome to the show my good friend and colleague, the illustrious Dr. Alex Crespo. Dr. Alex Crespo is an orthopedic trauma surgeon. He is the director of orthopedic research at Endeavor Health in Chicago, Illinois. Me and Dr. Crespo go back a long way. He was my chief resident back in the day at NYU, so he's got plenty of stories about me from my training, and I think even before then, when I was doing research at at NYU with Dr. Ken Eagle, our mutual mentor. Tonight, we're going to get into value-based care. I write about it all the time, and we've got an expert in the house. The Transforming Episode Accountability Model. This is a mandatory bundle that is set to go live in January 2026. These are mandatory bundles. People are going to be responsible for the cost of care in the 30 days after discharge. And one of the care episodes in this bundle is hip fracture. Anybody who takes care of these patients knows these are very difficult patients to take care of or to be able to predict cost or outcomes in. And my good friend here, Dr. Alex Crespo, is an expert when it comes to taking care of these patients. Welcome to the show, Dr. Crespo. We're excited to speak with you today about your skilled nursing facility surveillance program and more.
Dr. Payan, it's truly an honor to be with you, and this is a decade plus coming. We finally made it to the big show.
Absolutely. So, I think to orient the listeners, because the Techie Surgeon audience, I feel like, is broad. We've got innovators, we've got other clinicians, health executives. Some folks just want to learn about AI when they come to the newsletter or the podcast. What is value-based care? Tell the listeners a little bit about that.
Yeah, I mean, in its simplest form, right? It's creating an incentive for alignment of care. If you really want to break it down, we think of value and its relationship between quality metrics and cost, and the
Right.
better quality, the lower cost, the more value that you have. But we then become aligned to those things based on either defining the goals of what the outcomes are or the cost that we provided at, or both. And the
Beautiful.
better we play that game, the one I will say, I think the better the patients do, and two, the better the institution that you work for will do.
Yeah, yeah. We talk about that equation. You just alluded to it, right? Like you've got outcomes divided by cost, and you want costs to be small and outcomes to be big and good. We're trying to shrink the denominator. Tell us about this program that you started at Endeavor Health for your hip fracture patients.
Yeah, it really, I've got to give a big hat tip. You mentioned Ken Eagle. This was really work that started with himself and Nicole Stevens at NYU. For a little bit of background, uh, while you and I were both even at NYU in the early 2010 to 2015 in particular, while we were there as research coordinators and then early residents, value-based care was this oncoming wave.
Yeah.
And Joe Zuckerman, our chairman, I think was he had a lot of foresight in seeing that coming and installed a lot of change in the arthroplasty department. And while we were there, and the years leading up to when we were there, by the time we left, this transition from inpatient arthroplasty to outpatient arthroplasty was really monumental. And they're now leaders in that space. And if you look at, their evolution as a healthcare system over the past 10 years, even, a lot of that is because of the foresight they had. All right. So I start there because I think what they've started to do is realize, well, value-based care is now coming for trauma. And in trauma, it's coming for hip fracture patients. And so if you take that mentality and say, okay, we're being asked to change the way we do things, there's this movement towards not outpatient hip fracture, right? But it's really, instead of outpatient, it's can we get hip fracture patients to recover at home? All right. And that is the most fundamental takeaway, is that if you are being asked to perform in a bundled environment, the biggest piece of the pie in the hip fracture world goes to skilled nursing facility use, right? And so we can really start to dive into this and dissect it. But basically, our program came out of this idea of we actually looked at how we were performing the bundle and we weren't doing so well. We do a ton of hip fractures. We're one of the highest volume hip fracture centers, but we actually were operating at a net deficit in our hip fracture program. We were better off closing our doors and saying, we're done doing this from a financial perspective than doing it. And we started to look at why. We realized we can start to get people home. We built programs around that. And so I'm happy to discuss that more, but I do
Yeah.
to start where it was. A lot of that was adopted from NYU and from the work that they did and Ken Eagle did.
Very good. Credit given where, credit is due. Absolutely. I think both of us were sort of indoctrinated with this idea of care transformation, of wanting to really ride this wave of a new way of delivering care. Hip fractures are hard, right? Over 70% of these patients at baseline are usually going to a skilled nursing facility. And I think a lot of surgeons and patients would probably say that's for a reason. These are frail patients. These are people with a lot of medical conditions that make it hard to go home. And you and me both know the other piece of this is unlike a total knee replacement or a total hip replacement, which maybe some of the listeners have had themselves or know a family member who have had, you don't get to choose, right? When you're going to break your hip, when you're going to have surgery. And we don't get to choose or decide how sick you are when we fix you. So we're kind of both given the cards that were dealt. And it can be really challenging, I think, to get patients home. I definitely have struggled with it. I think the metric that we usually try to really hone in on is this idea of getting patients surgery as fast as possible. So tell us a little bit about the nuts and bolts of this. And like you said, right, just to orient everyone here, that's the big lever to pull when you're trying to contain cost is shortening that window of time that someone is in skilled nursing facility or stopping them from going to a skilled nursing facility location altogether. So tell us a little bit about the nuts and bolts of this. How did you implement? Who were the stakeholders you brought together? Maybe a little bit about the progress and the success to date.
Yeah. So we've called it the road home. We kind of created this entire team that was designed to helping patients get home. There's a lot to think about with it. One of the other, big things with hip fractures, as opposed to scheduled elective cases like arthroplasty, is that that patient woke up in the morning and, had no idea that they were going to end up by nightfall in the hospital. That means a couple different things. They are full of fear and anxiety, and they weren't prepared for this, right? So you can get a 75-year-old total hip replacement home after a scheduled total hip arthroplasty that was 3 months in advance because they had 3 months to think about, okay, I'm going to have my niece and nephew here. I'm going to make sure that we've picked up everything around the house. I can walk around. I've got my walker over here. My bed's going to be over.
Yeah.
They've got a plan, right? They've had a long time to think about it. That same 75-year-old with a displaced femoral neck that gets that same total hip arthroplasty, they woke up in the morning and had no idea they were having surgery within the next day and a half, right? And so it's the same surgery, the same operation, but they're nervous and they should be. They just had a fall. They're scared of falling again. Their family is scared of them falling again. They haven't set up their house. They don't know where their bed's going to be. And so it was really actually this understanding that a lot of what we're doing is, is treating fear and anxiety, is
Yeah.
patients
You're
to
coaching
understand.
people.
It's coaching. Uh,
Yeah.
it's a lot of social work action.
Mm-hmm.
And so we created a team. It's myself, our head of nursing, our head of physical therapy, our head of social work, and our lead floor PA. And we go, we see every hip fracture patient on the floor, we talk to them, we talk to their families, and we start to identify who we think can be home. There are certain people that we don't think can be home based on how they're doing with therapy, and then really making them feel comfortable about getting home.
Yeah, tell us a little more about that. How are you, almost sounds like a scorecard for a patient. What are the criteria that make you say, all right, this is someone that I think I can discharge home. What are you asking the patients? Is it a set of standard criteria that you're going through?
Yeah. In the total joint arthroplasty world, there's this mantra, right? Your preoperative range of motion dictates your postoperative range of motion. And I think of it the same way, right? Your preoperative level of function and independence dictates your postoperative level of function and independence. So we ask every patient the same things, right? First of all, what do you want? So we explain to them, look, home is best. Our readmission rates are dramatically lower. Our infection rates are lower. Our patients are happier when they're home. If we can get you there safely, that's the best place to be. But what exactly do you want? And there are some patients that will just tell you,
Flat
I'm
out.
going home. Like
Yeah.
I can't go
Sure.
home. I'm scared to be home.
Mhm.
You know, my kids live across the country, whatever. Those are not patients that you want to spend a lot of effort or make feel ostracized by trying to extend a hand to get them home. What
Yeah.
you'll find is that probably 80, 90% of them on day zero before surgery, right? They say, I'm going home. I want to go home. And so we take that and we say, okay, good. That's actually the quote unquote right answer.
Yeah.
Then tell me more about you. How many stairs do you have at home? Did you use a walker or a cane before this injury? What family members or friends or social network do you have in the area? Those types of pieces of information will start to tell you a little bit more about who is this person, how fit are they, and what support systems are going to be available for them at home.
Yeah. Yeah. And I think that it's really interesting. It's kind of a contrast to what we're seeing with patients who are having total joint replacement, where they're nervous about going home. A lot of hip fracture patients, to your point, they want to go home, but some of them cannot, should not, or the caregiver, the people who are supposed to help get them home really feel uncomfortable. How do you coach the patients that you feel are appropriate to go home, to overcome that fear and anxiety that you mentioned? And how do you speak to the family about this plan after this major injury, this usually, small surgery for us, but huge surgery for them? How do you tell them, okay, like, we're going to equip you physically, mentally, environmentally to go home?
Yeah, this is where the road home, the title, came from. So what we started to realize as we did this more and more is there's this kind of prescribed series of events that happen over 4 to 5 days. Um, and the way we explain it is on day zero, everyone says they want to go home. On day one, after surgery, everyone feels like they're never going to make it. They feel awful the first day. We're trying to just get them to walk about 10 steps. And then we have this graphic in the room as we show them how we're going to coach them through this. So we're looking for 10 steps on day one, 20 on day two, 40 on day three. By day four, you're doing 75 to 100
Mm,
feet. You've done one or two stairs, and we get you home. Having that graphic and having a system where people feel a sense of trust that they're at a place where you do this a lot. You have a
yep.
system, therapists, the nurses, the care workers are all on the same team. They
Mhm.
they start to trust you. And that is how you treat the fear and anxiety. And then they see, look, I did 15 feet on day one and I did 30 feet on day two. I'm actually a little bit ahead of the curve, even though I don't feel great. And they start to just believe in themselves. And that's how you slowly get them over the
That's
hump and
that's
where they want to be.
That is awesome. That's all. And I think that people are visual learners at baseline, and to be able to see that scorecard, that, kind of steady takeoff, if you will, and how
Yep.
far they're walking goes a long way. What are you using there? Is there, this is a techie podcast. Is there an app? Is it or is it laminated?